Welcome to this explainer on enteral nutrition. Today we're going to walk through a clinical decision tree to help you safely feed patients and, more importantly, prevent some truly life-threatening complications. Whether you're managing a patient post-stroke or balancing the metabolic tightrope of someone in the ICU, getting nutritional support right is absolutely critical to their survival and recovery.
Okay, let's just jump right in by defining exactly what we mean here. Enteral feeding is the delivery of nutrients directly into the gastrointestinal tract when a patient just can't eat adequately on their own. But, and this is the absolute key point, their gut still works. We are bypassing the mouth and esophagus, sure, but we're still putting the body's natural digestive engine to work.
And that brings us to a phrase you are going to hear all the time. It's the absolute golden rule of clinical nutrition. If the gut works, use it. You should only ever bypass the gastrointestinal tract and use intravenous parenteral nutrition when digestion or absorption is completely 100% impossible.
So here is our game plan for this explainer. We're going to cover the 3 clinical questions: preserving gut physiology, choosing the feeding tube, ICU strategies, and finally managing complications and refeeding syndrome. Let's get to it.
All right, Section 1, the 3 clinical questions. This is our decision-making algorithm to figure out exactly who needs support.
Whenever you have a patient who is unable to eat, you've got to assess them with 3 sequential questions. First, do they actually need nutritional support? Second, can they swallow safely? And third, does their gastrointestinal tract work? If they need nutrition, cannot swallow safely, but hey, they have a functional gut, then enteral feeding is your go-to. It's a remarkably clean, logical pathway.
Now, to answer that very first question about whether they actually need nutritional support, we don't just, guess by looking at them. We rely on objective anthropometric criteria to catch malnutrition way before major physiological complications set in. An established malnutrition diagnosis is a BMI under 18.5. But we really want to look out for the early and significant warning signs, like an unintentional weight loss of more than 10%. We absolutely have to catch nutritional depletion early, before their muscle and fat stores are dangerously compromised.
Section 2. Preserving the gut physiology. Enteral versus parenteral nutrition.
So, if the gut works, why is it such a huge deal that we use it? Well, the physical presence of enteral nutrients in the lumen actually maintains healthy intestinal architecture, tight junctions, and a normal gut microbiome. On the flip side, intravenous parenteral nutrition completely bypasses the gut. And without those nutrients in the lumen, you get rapid villus atrophy, a seriously weakened mucosal barrier, and bacterial translocation. That massively spikes the patient's risk of getting a systemic infection.
Moving right along to Section 3, choosing the feeding tube. Gastric versus post-pyloric, and NG versus PEG.
Once we confirm the gut works, we hit a literal fork in the road, the stomach or the small intestine. If gastric emptying is totally normal, we feed directly into the stomach. It's physiologic, it's straightforward. But if the stomach is retaining feed because of gastroparesis or an obstruction, it's just going to fill up like a water balloon. In that case, we have to bypass the stomach entirely with post-pyloric feeding directly into the jejunum. That is how we prevent vomiting and dangerous aspiration.
And here's a pretty interesting quirk. Our tube choice completely dictates how we confirm its placement. Because the stomach is full of hydrochloric acid, you can safely confirm a nasogastric tube right at the bedside using a simple acidic pH aspirate. But the jejunum? It doesn't have that gastric acidity. An aspirate from down there is going to be neutral, which, terrifyingly enough, is the exact same pH as the respiratory tract. So post-pyloric tubes literally always require an abdominal x-ray just to make sure they aren't sitting in the patient's lungs.
Okay, next, we decide how the tube is actually getting into the body. We're choosing between an NG tube, which goes right through the nose, and a PEG tube, which is inserted endoscopically through the abdominal wall straight into the stomach. And listen, this decision doesn't actually depend on the patient's underlying diagnosis. It depends entirely on one thing: the expected duration of feeding.
Specifically, 4 weeks is your threshold. Keep that number locked in your mind. If your patient needs nutritional support for less than 4 weeks, you go with a temporary nasogastric tube. But if they need support for anything longer than 4 weeks, an NG tube is just going to cause way too much nasal and esophageal irritation. So a PEG tube becomes the standard of care.
Now, if you do insert a PEG tube, I need you to remember the number 2. It takes 2 full weeks for a mature fibrous tract to form between the stomach and the abdominal wall.
Why is that absolutely crucial? Because if you remove it prematurely, before those 2 weeks are up, the stomach can actually separate from the abdominal wall. That spills gastric contents directly into the peritoneal cavity, which causes fatal peritonitis. It's a massive deal.
Section 4. ICU feeding and gastric function. Managing critical illness.
Let's zoom into the ICU for a second, because the rules kind of shift in this high-stakes environment. While a healthy stomach handles intermittent bolus meals perfectly fine, mimicking how we normally eat, critically ill patients need a totally different approach. They mandate continuous pump feeding. It's a slow infusion that keeps gastric distension to a minimum and provides a much steadier delivery of carbohydrates, which is really helpful for managing their blood glucose.
So why exactly are bolus feeds so dangerous in the ICU? Well, these patients are dealing with profoundly delayed gastric motility. Their gut just isn't moving. This is driven by deep sedation, opioid pain medications, physiological shock that pulls blood flow away from the gut, and massive sympathetic activation from high catecholamine levels. If you dump a large bolus feed into a stomach that is essentially paralyzed, it just backs up, creating an immediate extreme aspiration risk.
Finally, Section 5. Complications and refeeding syndrome. These are the highest stakes risks we face.
Getting the tube in safely is really just half the battle. The major complications usually fall into a few distinct categories. Mechanical issues like aspiration, which is when the feed enters the lungs, and diarrhea are super common. Then you have stress hyperglycemia, which means we have to do strict glucose monitoring and insulin titrations. But while those all require constant vigilance, the most lethal threat to your patient isn't mechanical at all. It's entirely metabolic.
I want you to track with me on this step-by-step breakdown of refeeding syndrome because it's wild. Step 1. Prolonged starvation severely depletes the body's intracellular electrolytes even if their blood levels look perfectly normal. Step 2. We suddenly restart feeding them with a carbohydrate-rich enteral formula. Step 3. The patient's pancreas freaks out at those carbs and releases a massive insulin spike. And Step 4. That insulin violently forces glucose, along with whatever phosphate, potassium, and magnesium is left floating in the blood, straight into the cells.
This sudden massive intracellular shift causes profound hypophosphatemia. That is the hallmark biochemical abnormality of refeeding syndrome. Without phosphate, the body simply cannot synthesize ATP. You are literally stripping the patient's cells of their energy currency. This rapidly leads to respiratory muscle failure, lethal cardiac arrhythmias, and honestly, death if you don't catch it immediately. So, spotting those high-risk patients early? That is your best defense. If you have someone with chronic alcohol misuse, severe recent weight loss, or prolonged starvation, you absolutely cannot just turn the feeding pump on to full speed. You have to initiate feeding incredibly slowly. You've got to aggressively replace their electrolytes, especially phosphate, potassium, and magnesium. And you must always supplement thiamine before those carbohydrates go in.
Because as we've seen throughout this explainer, enteral nutrition is clearly way more than just pumping in calories. It actively preserves immune function, defends mucosal integrity, and literally dictates patient survival. So the real question is, how will you apply these clear, structured algorithms we talked about today to avoid those mechanical and metabolic disasters and truly heal your next patient? Thank you so much for joining me. Keep these frameworks in mind, and I'll see you next time.